have in common. I've worked with Bonnie for many, many years, and we started with doing child abuse and started teaching about elder abuse. And another area that I have interest in, we're not going to talk about today, is police use of force and excessive force. What do all of these have in common? Basically, it's bullying. I don't like strong people that hurt weak people. I just fundamentally, as a human being, don't like that. And I don't have a dog in the fight other than finding the truth, whatever that truth is. And that's something that's really important to remember. And Bonnie has found this incredible balance, and her strength in being able to stand here and tell you that story and to not be as angry as I know I would be is a testament. But I will tell each and every one of you, as much as it hurts you as a human being to see this, remember that your anger is a weapon against you in working the case. You have to be objective because you may not get it right. Very important to remember that it's all an investigation, and until somebody is actually found guilty of a crime, they are innocent. And the way I learned that, actually I have to, how many people from Charleston do we have? All right, so you know my brother-in-law, Ashley Pennington, who is the public defender here. Imagine what that's like. I trained at MUSC, the medical university here, and oh, by the way, forensic pathologist, my brother-in-law is cross-examining me. So you know we had some interesting discussions over the dinner table. But I learned from him, he is singularly one of the most ethical people I have ever met. I think the world of Ashley. He has taught me so much about my job. So anyway, with that, what I would like to do is kind of cover, and I have to give you some disclaimers. So, Bonnie, your time's up. Have you give a couple of disclaimers. Commercial interests. This is not a commercial for my book, but Ethics in Forensic Science. It's available on Amazon, and it's actually pretty cheap. I will tell you right now, what you're going to see here is forensic pathology. It's graphic. It's not for everyone. I'm not showing you these pictures to shock you. I'm not showing them for the gore factor because I don't believe in that. To me, the singularly most important person that I work for is the victim. I never forget that. I never disparage a victim. Occasionally there's dark humor in my field. I am not one that participates in that because I remember the victim and I think, there but for the grace of God go I. There but for 15 seconds, I'm in the same situation that Bonnie had to face the last 23 years. I never forget that. So I ask you to never forget that, and I know it's hard. A lot of people deal with things in different ways, and I respect that. I'm just saying that you'll find that I don't. So this is, for me, about the victims. And the statistics are out there. You've got them in your handout materials. But there's several different types. We all think about physical, and being a forensic pathologist, I think about physical abuse, but there's also neglect and psychological abuse, and unfortunately sexual abuse. We'll cover a little bit that towards the end, time permitting. But 3.7 million reports and 750,000 substantiated cases. And those numbers are only going to increase with population. Staggering. Think about that. You know someone. When I was in high school, I went to high school here in Porter-Gaud. We had a sexual predator who everyone knew was a sexual predator. And I'm not going to memorialize the guy. Everybody from Charleston knows his name. But he got everybody he got his victims from my classmates. My classmate's little brother is actually the poster child for Darkness to Light program. I do what I do for people like that. Never forget. You can forgive, but don't forget. So, we're here to get facts. What are the facts? When you're investigating any kind of child injury, and one thing as a forensic pathologist, you probably think, well, he works with dead people. Actually, I don't. I work with living victims. I work with child abuse living victims, sexual abuse living victims. I work with anybody who has injuries. So I'm happy to look at any case. and give you an assessment. I fundamentally believe that's important. But you also have to remember I'm a physician, so what I can do is limited. I can look at wounds and assess wounds. I can't necessarily tell you how they happened. There are certain things that are pattern injuries that I can say this had to happen this way, or that entity known as shaken baby syndrome, which is a term I don't personally use and haven't used for a long time. When we get there, I'll tell you why. But you have to investigate cases. So, this being near the Ides of March, I have to tell you about where forensics came from. It actually came from Julius Caesar. When he was assassinated, a physician, a member of the Senate named Antistius, did the autopsy examination on the body and found that of the 23 stab wounds, one had actually penetrated between the first and second ribs and got his aorta, and then had to testify about that before the forum. Hence the origin of the term forensics. It actually started with a medical examiner. How about that? Pretty cool. All right, so medical. Diagnosis. Medicine is not a bench science. They're fundamentally different. As dentistry is not a bench science. They are different specialties. So someone that says that you put a blood sample into an instrument, you get a DNA profile out of that, that's not the same as being a physician, a dentist, and starting with a patient. We actually have to gather our data, create what's called a differential diagnosis, which is what might be the problem here. Then we have to test and evaluate. We have to go back and look at our hypothesis and consider that, and it's always evolving. We can change the diagnosis as we get more and more information. That's not the same as putting a blood sample into an instrument and getting a DNA profile where the answer is either this or this. And the fundamental difference, if you think about it, a bench scientist goes to college, gets a 4-year degree. They might get a master's degree or a doctorate degree, but it's in that specialty. In dentistry and medicine, we start from the very beginning in that differential diagnosis. We are trained to exclude extraneous information and seek out important information. So there's an important difference between medicine and bench sciences. What's the first thing that happens when you go to the doctor? As I did at 2 o'clock this morning. Everything's fine. Wasn't me personally, but what's the very first thing that happens? Exactly. Follow the money. You know why? Greens fees are expensive. Okay? They always get the money up front. Although in an emergency, like last night, they actually treated the patient first and then got the money. But you always get the money and they will track you down. But, so it's, the important thing is, why are you here? So medicine starts with history, and I bring that up because there's a big movement now in all forensic disciplines to eliminate bias. And bias in my field is code for history. I don't need history. Well, I'm sorry, that actually is suborning medical malpractice. To tell me that I don't need history is asking me to commit medical malpractice. So on its face, it's ridiculous. So when you hear people say, oh, you bias, no, actually we are specifically trained about that from the very beginning of our practices. And in order to be a physician or a dentist, you've got 4 years of doctorate level training. Then you've got the residency and fellowship, and it's quite a haul to do it. So what do we do when we get this data that I talked about? Why are you here? We get the history of present illness. We get a past medical history, what's been wrong with you in the past. We get social history. Do you drink? Do you smoke? And family history. Oh, your mom had a heart attack? Your dad had pancreatic cancer? What's up with that? After we get the history, we then do a physical examination. So we start with history. It's integral to what we do. After we do that physical examination, we do laboratory tests that help confirm or exclude diagnoses. Now, we do the same thing in forensic pathology. It just happens that most of our patients are dead. You know, they probably didn't mean to do that. They just kind of ended up that way. But it's no different than any other field of medicine. We start with a coroner will send me a case. Why is your patient here? Well, we think they might have had a drug overdose. Okay, that may be the only history that I get, and I have to work with that. But that helps direct my examination because, okay, I'm thinking this could be a tox case. Not that it is a tox case, or they have a gunshot wound to the head. Okay, well, that may be self-inflicted, like your history says, or it may be a homicide. We've got to do an investigation. I can look at a case and say it's a contact gunshot wound, but we have to actually investigate it. And we cast a wide net with the differential diagnosis. What is the global universe of what this problem might be? And then we come into, okay, how do I prove or disprove this diagnosis? For example, in child abuse. Is it definitely inflicted injury or not? And how do we make that determination? Sometimes we have to go to the literature. Most of the time we don't, because actually, you know what gets in the medical literature? It's not the stuff you see every day, because nobody needs to read about that. What do you see in the medical literature? You see the odd ducks, like the guy who drank WD-40. That's going to be a case report, right? Because nobody's seen that before. So what we do is we get that differential diagnosis and we start pruning that tree. We start cutting back. Okay, how do we eliminate coagulopathy, a bleeding disorder? How do we eliminate a fall from the couch? How do we do this? And part of its history, part of its exam, part of its investigation. We combine all of these together. And the main thing we were concerned about is safety, obviously. Safety for the patient and safety if there are other children in a child abuse case. So we actually have to make sure of that. We try to be safe for the patient in getting testing. You go from least invasive to most invasive. And you try to use your database as a resource for the continuing and pruning. And the value of all this testing and everything is confirmation or exclusion of different potential diagnoses. So let's start out basically at a simple differential diagnosis, if you will. You have a sudden death. You basically have two options there. Either there's trauma or there's not. It's pretty easy. If there's not trauma, then actually what I have to look at is, okay, there's not trauma that I can see. But there's environmental trauma, heat, cold. There's chemical trauma, drugs, poisons. So it's not quite as simple as, oh, no trauma. Or if there's trauma, why? So let's do a case. This young child comes into the hospital with a skull fracture. Sutures are widely separated. The brain is swollen. The child is basically brain dead. Has a left parietal skull fracture you can see in the picture here. So the question is, what? Is this abuse? Do you know the answer? The history is the child fell from a window. So what do you think? This is the interactive part of the show. So feel free to just shout them out there. Yes, ma'am. Exactly. The answer was possible neglect from lack of supervision. And what would you need to know? Was there supervision? Right? It begs the question. And the easy way to practice forensic pathology, I'll give you a hint, prosecutor's defense, the question is why? Why did that happen? And my job is to try to answer that question why. Sometimes I can, sometimes I can't. So in this case, we actually do have a history that I'll get to. But when I get that history, is it a suspicious history? This child sustains that from falling off a couch. Anybody think that happened? I would certainly hope not, because that's not the kind of injury you get from falling out of a couch. And you don't typically die from falling off a couch, but you can. You just die in a different way. Again, the why is important. So what happened? Again, that comes down to history. So it's all together. So here's the window. Did anybody see a second story window? Oh, did I leave that part out of the story? Guess what? Your history is oftentimes incomplete. And you have to recognize. Now, in this case, this happened in Mobile, Alabama, where I was for 5 years. And in that jurisdiction, the medical examiner went to every homicide and every suspicious death. So we were actually on scene. Now, in South Carolina, Georgia, where I am now, most counties in Georgia, Alabama, most counties, we have coroners. And coroners are sometimes very good, and sometimes, guess what? Everybody's heard that about coroners, I'm sure. What you probably haven't heard a lot of, sometimes medical examiners are very good, and sometimes You hear me? So, yes, ma'am. The question or the comment was some states the coroner is not supposed to have or doesn't have to have a medical background. South Carolina is one of those. Georgia is one of those. Alabama is one of those. Guess what? Medical folks, having a medical background doesn't make you any better a death investigator, because you know what? In my specialty of medicine, I spent, how long was it, Heather? 6 years? Ridiculously long. Learning how to investigate deaths. So to say that somebody who does OBGYN, for example, as the former coroner in New Orleans, I believe he handled Katrina, he was an OBGYN. I don't know where you get the training for death investigation in that specialty. Last time I thought that was about bringing life into the world. What do I know? I'm just a forensic pathologist. We hide in the basement and, so having the medical training, you would think would be very good, and there are very good physician coroners. Likewise, there are non-physician coroners who are very good, and there are other, so that's not the part. The part is, if you have a lay coroner who knows what I can do and lets me do my job, and I know what they can do, and I let them do their job. And I'll give you a real good example and a plug to my good friend, our coroner in Savannah, where I live, who is a physician, who replaced a physician. Our coroner is a retired orthopedic surgeon. I don't really know about setting bones in folks that are dead, but he is a great guy, and he knows what I can do, or could do. I've actually retired from that post and doing my working for myself now, but you get the point. What you want is the right professional that cares. And every single person in this room has demonstrated that caring by being here. So you're already ahead of the game. So anyway, back to this. What do you notice about this scene just looking at that picture from the window? Well, what I notice is it looks like there's a pretty short distance from that window to the floor, doesn't it? Because you have to fit a floor in there. And the fact is that's 12 inches from ground level. So your comment about lack of supervision is pretty spot on. How did that kid get out the window? Because I can't tell you that that's a homicide or not from the photograph, but I can tell you that that kid had to get out the window somehow. That's the element here that needs investigation. Why did that kid get out of the window? In this case, the history that I got was he was jumping on a bed that was a mattress, laying on the ground, and he jumped and fell out the window. I can only tell you that's the investigation, and if I'm doing the case, that's what I have to work with. So that brings us to cause of death, which is the medical part. Cause of death is the initial event that set in motion the unbroken chain of events that caused the person to die. Does it sound like I've said that a few times in my career? Initial event sets in motion, unbroken chain of events caused the person to die. Pretty easy. Gunshot wound, what's the cause of death? Gunshot wound. It isn't rocket science here. Okay? Heart stop. Well, no, see, that's a whole different issue. Cardiac arrest. All right, so I have to mention that. On the death certificate itself, it says, don't use the term cardiac arrest. Now, why is that? Cardiac arrest. What does that mean? Let's break it down, because docs like to use big words. Why? Again, did I mention greens fees are expensive? Okay? So, cardiac, heart, right? Arrest, stop. So if you say they died from cardiac arrest, literally what you said is they died from being dead. Because last time I checked, 100% of people who die, the heart stops. 100%. Or you have another option in that whole differential. You could say respiratory arrest. Lungs stopped. Or the really one I really like, cardiorespiratory arrest. They're double dead. Okay? You don't use things like that. You use the initial event. So if someone goes into the hospital from a car wreck and they get pneumonia, completely not part of the wreck, but followed while they were in the hospital, what did they die from? They died from the car wreck because of an unbroken chain of events. So you go back to the initial event. And that gets a little complicated, and legally it's a little frustrating because if somebody dies of, say, pneumonia. Why do they have pneumonia? Oh, because they broke their neck. Why did they break their neck? Well, 20 years ago, they were a security guard at a liquor store. Guy came in to rob them, and he shot the off-duty cop in the neck. What is that death now? Well, homicide. He said murder. It's actually a homicide because I don't editorialize. When I use manner, so we'll talk about manner now, I have 5 choices. Natural accident, suicide, homicide, undetermined. 5 choices and only 5. Some states give you a 6th one, most don't. The 6th one would be medical misadventure. You like medical? The doc screwed up, but we're not going to say that because there's that thin white line. All right. Well, guess what? If I'm honest, and I try to be honest, I don't cover for people. That's an abomination to me because guess what? If I'm covering for somebody, the next one is on me because I allowed it to happen and I know better. So it's actually, in my mind, it's actually worse to cover something up because you knew it. Anyway, so homicide would be my call there if I showed the investigation. Now, prosecuting it, I bet, would be a nightmare 20 years later. Defending it, on the other hand, that's, of a homicide case, that's probably the best you're going to get, right? I mean, it's an easier case to defend because you have all this intervening time. And then you can question therapy, and was there medical misadventure along the way, and yada, yada, yada. Anyway, so we understand each other cause and manner. Those are my ultimate things that I get down to. And some MEs actually don't like determining manner because I have to rely on investigation, and that means it may be coroner investigation, it may be law enforcement investigation, it may be both. For example, the agency I used to work for doesn't have investigators. They have specialists who take phone calls, and basically what they do is they receive secondhand information, and based on that secondhand information from the coroner, from the cops, they are provided a history and then relay that history. So I'm actually getting a third-hand version of events. That's not good death investigation. That's not best practices. You want to get first-hand information. So when I do a case where I don't go to the scene, I get photographs. And the people that I work with know I'm persnickety about getting photographs. I want to see them because I want to understand what's going on. Because I want to reconstruct the scene. My goal is to reconstruct what's going on. I want to talk, if I'm an investigator, the first responder. Who first found the person? How did they find them? What was going on? Do a reconstruction. And that means get a doll and go to that first finder and say, take this, show me how you found this child. Show me what happened. Do it. And oftentimes parents are very frustrated, especially if it's not a homicide. All I can tell you is the tool that I've used in that situation is, look, we're trying to help your child. We're trying to help understand. Please help us do this. Help us understand. Exactly what you did in the photograph and video. Why? I like double backup. Photograph, video. Also, the bedding, clothing, anything else that might be associated. Document that and, bring it in to me for my examination. Again, I'm kind of persnickety. And what this does is it goes down to some criteria for getting things into court because we are talking about abuse cases and homicide and different jurisdictions. I don't know if South Carolina is a Daubert state or not. Daubert is a different set of federal criteria as opposed to the general acceptance rule. Anyway, these are elements that the judge can use. Is it tested or testable? Well, medical principles, again, this relates to bench science. This doesn't relate necessarily to medicine. It's a different specialty. So can I test an autopsy? Scientific basis, I think we're pretty well done. We have a medical basis. Known error rate. Is there a known error rate for autopsies? Well, that's a good question. The answer is there are established certain general knowledge about that, but you don't know what you don't know. And the judge decides if it comes in or not. And I think that's the model that most people are going through. And also, those are suggestions for the court. The court can ignore all that. And they can let anybody be an expert. So that leads me back to diagnosis. I have to have a sound scientific basis. I may not know the cause of my diagnosis. It may be pulmonary hemorrhage. Why do they have a pulmonary hemorrhage? I may not be able to answer that question, but I can continue to work on it. And if you have something like a syndrome where there are multiple different features, those features may or may not be present. It may have some, all, or even possibly in some cases, none of the visible features. So that's what medicine varies a lot. And it may be an atypical presentation of a typical disease. You're just not recognizing it. Not many people would recognize intense abdominal pain as a symptom of anaphylactic reaction. But it is. Why? Because your mast cells are in your GI tract, and your mast cells are what release histamine. So one of the little known, but most people get welts and hives and that kind of thing, and they have airway troubles. But isolated abdominal pain, most people might not see that one. So that's the thing we reassess and we go forward. And levels of certainty. We have things that are certain. Very little life is certain. I cannot tell you with certainty that a UFO won't land on the building and here at the door now. But I'm pretty sure that's not going to happen, right? So, but I'm not certain. It could happen, theoretically. But I'll tell you, probably it's a safe bet no Martians are coming through the door. Well, Martians might come through the door. It could go either way. Well, you know, theoretically, it could be. It is possible. And this is a question I get a lot in court. Is it possible that? Well, anything's possible. It depends by what you mean by possible. Reasonably possible, no. But if you're just using the word possible, I can take a quarter out of my pocket. I can toss it in the air. And it's possible that it comes down and lands on its edge. Because that edge is flat, right? And it could stay there. But it's not very likely, is it? So what do we mean by that term possible? It's not reasonable that's going to happen. Coincidental, there's no relation. And then I don't know. And I don't know in medicine is undetermined manner. So, Pygmalion effect. Pygmalion, that's actually one of the moons of, I believe, Uranus. I'm not positive about that, so if I'm wrong, I apologize. Pygmalion, it is what I want it to be, right? I want the statue to be alive, therefore it's alive. Well, that's the beauty is in the eye of the beholder. So the point here is that bias issue. You don't want to be biased and see what you want to see. Not every case is child abuse. Not every case is SIDS. So this is a real case. It's a death investigation. Until an autopsy is performed, it would be difficult for us to say one way or another if this is suspicious. You agree with that statement? That was in the newspaper. I'm sorry. If I have a 2-month-old that dies with no history, that is de facto suspicious. If you aren't suspicious at the beginning, so be suspicious. That doesn't mean it's a homicide. That doesn't mean anything happened. But be suspicious. Don't just completely dismiss it from the get-go. That doesn't mean that everything's a homicide. That's what I mean about that bias issue. Consider the possibility. So infant death investigations require detail because I need to get to that cause and manner. Cause, what did they die from? Manner, why? Because if we can catch the cases that are unnatural and accidental, we may have the ability to identify risk factors like bed sharing. That can save lives. Like putting children on their back to sleep. We can save lives. We can also recognize product defects. If there's a problem with a bassinet that's causing children to die. Where do you think seatbelts came from, by the way? Airbags. They came from autopsies. Where did the discovery of what HIV can do come from? It came from autopsies. So we can do a lot of good, a lot of public health good. Hantavirus, if you remember that several years ago. Kurt Nolte in New Mexico. Shout out to Kurt. Recognized that and saved lives. So that brings us to sudden unexpected infant death. Now, you've also heard the term SIDS for a long time. SUID is a new term. Sudden unexpected death in children is basically the same thing as SUID. What does that mean? Are they all the same thing and it's just like different terms and every 5 years they have to come up with a new term? Actually, no. And this is a very important diagram for this segment. This is probably the most important thing. SUID is a broad umbrella. You have SIDS as one of the components there, one of the spokes. But if you'll notice, you also have environment, hyperthermia. You also have poisons. You also have suffocation. SUID just means you have an infant who's dead. And I can't explain why right now. That doesn't mean that I won't be able to later or get an investigation and narrow things down. It just means that an infant is dead. So don't confuse those two terms. It's very important to understand that a small percentage of SUIDs are going to be poisonings. A small percentage are going to be accidental overlay suffocations. A small percentage are going to be homicides. But in your case that you're investigating, I got news for you. It's either 100% overlay or it's 100% suffocation, because an individual case is an individual case. So while statistics are great for generalities, you can toss it out the window because you may be looking at the zebra. You may be looking at the odd case, and it's your job to figure it out. That's why every case you should be suspicious about. The difference, SIDS is the natural death. SUID, we don't know. It's undetermined. External risk factors are present in SIDS, like the bed sharing, the unsafe sleep environment. There may be medical diseases as other risk factors for some of these. The key factor helps us determine cause and manner. So here's what I have to have in order to call something SIDS. I have to have a complete medical history review. That's birth to death. All right? I have to have a complete autopsy with toxicology and histology. And I have to have a thorough investigation. Without those, it by definition cannot be SIDS. Cannot be SIDS. And I'll tell you my little story about why I don't use the term shaken baby syndrome. I had a case of a child that was in foster care that was violently shaken to death, and I did the case at that was 92, 91 or 92, I believe, here in Charleston. I did the exam. I called it shaken baby syndrome because that was the term that we used then. Several years go by. I'm actually in a different state practicing. I get a call from the Charlotte newspaper, wants to know why I signed out the death of this 4-year-old in foster care as SIDS. I said, excuse me? No, it was shaken baby syndrome. So as I found out, what happened is because the child was in foster care, they had to go before a judge to finalize the death certificate. The coroner was the one that did that. The judge asked what the child died from. The coroner said, and I got to do it the way I heard it, shaken baby syndrome. Judge says, shaken baby syndrome, I've never heard of that. What is that? Coroner says, well, I don't know. I think it's a rock group. True story. True story. Judge, well, what is that? I don't know. Well, what do you call it when you don't know what a child dies from? Oh, that we call SIDS. Now, this child was 4 years old. Does anybody have an issue with that? It's sudden infant death. So what does that mean? Once you reach your first birthday, one gift that you get is you can no longer die of SIDS because you're no longer an infant by definition. The terminology is kind of important. So SIDS is natural. It's not a homicide. 100% of SIDS cases are infants, and that means they're less than 365 days. Now, interestingly, there are some age associations that are important. Most SIDS cases between 2 and 4 months. Very unusual, less than a month. So you start thinking about other things like congenital diseases, different things. Most cases under 6 months. When you get out to beyond 8 months, I get very concerned. Very concerned. Not that it can't be a SIDS, it's just so unusual that the statistics tell me I ought to look at that case maybe a little bit more. Typically what happens, the kid's fine, they're put down to sleep, they're found the next morning in bed dead. Unusually they're put down for a nap. That's not the common scenario. Usually they're found the next morning. There's no noise, no anything. That's kind of how they are. Autopsy findings, you've got foam coming out of the nose. This is an exaggerated example. But the generic autopsy findings are nothing. I might have some petechial hemorrhages inside the chest cavity. Here you're looking at a picture of the thymus, which is the large pink organ on top, and then below that is the heart. This is a little different picture. The thymus now has been flipped up, and you can see that there are florid. All those little dark spots are petechial hemorrhages, and all the dark spots on the heart are petechial hemorrhages. In SIDS, you see those in the chest cavity, the lungs, thymus, and heart. All right, so there's something going on, though, here as opposed to this, right? A lot more here. Guess what? That doesn't mean anything. There may be a lot in SIDS. There may be also, unfortunately, a lot in homicidal suffocation. Now, as it happens, this one with more happens to be a homicidal suffocation. I can't tell you that from looking at the picture. Blood in the lungs, that's kind of a non-normal finding, and it should be a red flag. This is a child that came into the hospital. It reminds me of a story of a kid that had idiopathic pulmonary hemorrhage. And that's how the case was signed out. Natural idiopathic pulmonary hemorrhage. What does that mean? Idiopathic. It does not mean the pathologist is an idiot. But, just saying. In fact, that case turned out to be a homicide, and the people who did the autopsy missed the 12 rib fractures that were visible on the x-ray, and they missed the, I believe, in excess of 30 rib fractures that were actually present. That was the case that went for autopsy. So, like I said, not always is the pathologist right. You want to do the scene investigation, collect the bedding and everything. And one thing that, do you note anything here, investigators? Anything you would do here at the scene? You collect it, but I actually bother to look. And the reason I bring this up is the folks took the picture here because you want to take the picture, but that was it. It's like took the picture. Well, that isn't what you need to look at. What you need to look at is the actual pillow, because that's a pretty dark pillowcase. And if you look at the inset, does anybody recognize anything in that inset? Let me make it a little easier for you. How about now? All right? That's what pathologists do. That's a pattern recognition. And honestly, I look at that stain that you can see on the pillow, and I instantly knew what it was. I don't know how many people in the room did that. If you did, you might think about forensic pathology, because it's all visual. I see it, I know what that is, because I've seen that type of cell before. I've seen this pattern before. That's what forensic pathology, it's a visual discipline. So, just to show you, and I've actually had homicide cases where somebody was suffocated with a pillow. We may or may not get to that case, but same thing. Also, you got to think about artifacts. Like in this case, you see the picture on the upper, you see that kind of Elvis upper lip. All right? If that case comes in and I see that Elvis upper lip, and it comes in like that, I don't know why. Medically, I know why, because I know that that's usually found with an ET tube, endotracheal tube, that's taped in the bottom. But notice where in that picture the ET tube is. On the other side. So that little upper lip thing isn't from that. Instead, it's from the tape. The tape is pulling it up. So it makes sense. Also, something you might see when you're investigating a case, if you see little excoriations, little defleshing, where the superficial skin has come off, if you have a lot of acid in your stomach and you vomit externally, the acid in your gastric content, if it stays on contact with your skin, can actually cause a little burn on either side. Just an FYI. Sometimes you see that. Yep. Yes, sir. All right. The question is, some medical examiners don't use the term SIDS at all, and I respect that and understand that. Some people, and there are various acronyms, seriously inadequate and deficient study is one of them, and there are various things to help you remember it. Some people don't believe in that as a diagnosis. They think it's a garbage can diagnosis, that it's just basically you didn't do a sufficient examination. Well, the reality is that some people use it and some people don't, and I'm okay either way. My experience has been that I very rarely use the term because usually I can determine by an investigation what I believe to be the cause of death. Another thing, and thank you for asking that question because it reminded me of something very important I didn't get to. Cause and manner of death are diagnoses, right? So what does that mean? This is a very important thing to remember. Prosecutors, law enforcement, social workers, medical people, very important. Everybody in the room, very important concept. Their opinions. And you know what they say about opinions, right? So it's different people, different strokes for different folks. I have no problem either way. We will get to a case, I believe, in the second part of this that ties directly to this very issue. Okay? So, you come onto a death scene like this, scene investigators. What do you think? It's broken, it's smashed. I would love to show you more pictures, but the actual, who was a former cop investigator, took one, remember Polaroids? Remember Doc Veda? Nobody watches South Park? No? Remember Berries? Yeah? Got to get a few smiles there. It's, remember when they used Polaroids. All right? One Polaroid photograph. And believe it or not, I actually enhanced that massively to get that image to show like that. I did a lot of work on that picture. I have been doing this for 27 years. This child was allegedly found in that bassinet and found dead. Typical SIDS history. 27 years. This is the only time I've ever seen anything like that. Is that a red flag? Yeah, and I would hope that an actual scene investigator would catch that. I sure hope they would catch it before the case comes in for autopsy, because when I said, oh my gosh, I need to see that, it wouldn't have been thrown away and gone forever. That's why there's only one picture of that. Now, I can only tell you that when I did the autopsy, same generic SIDS type findings, but you know what? When the tox came back 9 months later, people that deal with this know what I mean. Blood alcohol of 0.12. Oh, ruh-roh. That's a Scooby-Doo case. Ruh-roh. We got a problem there. Why is that? Well, does that mean the child died from the alcohol? Well, it's very complicated, and Jerry can talk your ears off about the toxicology. I can tell you this. Little kids are not the same as little adults. That's not a postmortem artifact. It's a real number. Why would a little kid have a 0.12 blood alcohol? You ever had kids in the car on a road trip? Seriously, you can't tell me that all that Benadryl is for motion sickness, right? Here, oh, you're upset. Take some Benadryl. It's because you're telling me it puts you to sleep. Okay? Now, 0.12 is a pretty high number, which suggests to me, well, anybody here remember the first time they had an alcoholic beverage? And what happened? And anybody remember last weekend when you were celebrating St. Patrick's Day? Alcohol doesn't affect little kids the same way as adults. It tends to put people to sleep, especially that first one. So an infant whose liver enzymes aren't sufficiently mature to handle it, it's going to put you down. I would submit that probably this kid had this done in the past, because as happens in abuse, what does the person learn? They tolerate a little bit, so what happens? A little bit more, a little bit more, a little bit more, and there's a scale that's going like this. And all of a sudden something tips those scales. And folks, that happens to all of us in every walk of life, you know. Somebody who has a heart attack, they were alive yesterday with 95% blockage of their anterior descending coronary artery. Why today? Something tips the scales. It may be a little more alcohol, maybe a little stress, but what an abuser learns is you tolerated this in the past, so a little bit more is okay. And a little bit more and a little bit more. So, I don't have enough to call that case. I didn't make the call of a homicide. In retrospect, I may have. Because guess what? I learn as I go through practice, this case was 94. I've learned some stuff over the years. And I've actually learned that